All right, so we're going to talk about the psychological aspect, no conflicts or conflict of interest. But so we're going to talk about all of the things that don't involve the active chemical in the pill that people are taking, right? All of the things that affect how the patient does, how the patient responds, that have nothing to do with the active pharmacology of the medicine you're giving. And I hope to convince you over the course of the next 45 minutes or so that this is a much bigger deal than a lot of providers realize, that this is really important and it has a lot of different manifestations and shows up in a lot of different ways. We're going to talk about these four different ways, although they're kind of grouped into twos. The first is how the non-pharmacologic effects, and that's the way I'm going to describe everything except the active component of the pill, how the non-pharmacologic effects really affect the effectiveness of the medication, how they make a medication work or keep a medication from working, how just the act of prescribing medications affects the overall treatment and improvement of the patients that we're seeing. We're going to link that a lot to placebo and nocebo effects. So we'll be talking about those kind of together. And then we're going to spend some time looking at the meaning of medications. What does the medicine mean for the patient? How does that impact the treatment that we provide? And then the reasons to prescribe. We do a lot of prescribing. Why are we prescribing? We'll talk about some of those reasons as we get to that point. And there's points for comments along the way. But if you have questions, if you have thoughts, don't worry about stopping me or interrupting the flow. Just raise your hand, and we will get you in there as we go through it. And the first, I'm going to start off with a contention. This is found in a book, the Dr. Mintz book in 2022. That non-pharmacologic factors often influence the outcome of prescribed medication. We think of it in terms, and we spend an awful lot of time learning specific medications and their indications and their side effects, but a lot of what we do isn't determined by that pharmacologic effect. And in fact, in studies, the placebo effect may account for up to 75% of antidepressant efficacy. So if you had 100 people on an antidepressant, an identified antidepressant, and 100 people on a placebo, that placebo group is going to have 75% of the response that the antidepressant group does. Most of the response is actually a placebo response. That a strong alliance with the provider, a good connection, is perhaps more important than actually the medication chosen, right? There's lots of antipsychotics out there. Which you choose is less important than the relationship you have with that patient you're prescribing it to, and that there is a very strong correlation between the expectation of response and actual response. If a patient thinks this medicine is really going to help me, they are much more likely to have a positive effect. If they think this medication is a waste of time, then they're much less likely to have a positive effect. So I'm going to throw those out there. There are some articles that back that up and stuff. But the first question that we have for the group, and you can either chat or just unmute and answer this, any problems believing those claims? Any of those, based on your clinical practice, based on your experience working with patients and prescribing medications and watching medications work, any problems with those three, or is that consistent with what you have seen?
This is Moshe Torem. This is very consistent with what I have seen in my practice. Thank you.
Yeah, thanks. And a couple consistent. I agree. No, engagement is the key, right? So that's important to remember. And I'm going to talk a lot about things from a psychiatry point of view because that's the world I live in. That's the pond I swim in, that kind of thing. But I suspect a lot of this carries over into all aspects of medicine. But a lot of the work has been done in mental health. And I talked before about that relationship, that engagement with the patient, the alliance with the patient has a lot to do with the outcome. But just the act of prescribing may actually work against true treatment, right? Because what we hope to do with our treatment, when we have a patient who's sitting in front of us, we hope to have them feel better, have them healthier, and have them more functional. And sometimes actually prescribing works against that. Let me explain a couple of ways that you might see that. One is it shifts the focus from this global overall, are you functioning better? Are you enjoying life more? Are you having more interactions that are pleasurable? Two, very symptom focused, a very reduction here where you're just talking about side effects of medication, or you're talking about 1 to 10 scales in sleep or energy, and you're really focused in on those very specific things that you hope the medication does. And by doing that, you've lost the overall picture of how the patient is responding to treatment in general. You're losing the forest for the trees, right? Or you can't see the forest for the tree, right? You focus on the individual trees so much that you're missing the big picture. Sometimes, and we all have seen this, medications are taken in order to avoid making other lifestyle changes that would be healthier in the long run. I don't have to worry about what I eat. I don't have to worry about exercise. I'll just take a pill. That will control my blood pressure. That will control my blood sugar. I don't need to worry about what I do. That idea that for a lot of people on chronic medication, they lose that sense that they're responsible for their own health. They're responsible for their own wellness because they simply count on pills to do it for them. And in some cases, the most extreme cases, medications are used to avoid things that would be helpful for them. I worked in a PTSD clinic at the VA, which is the prime example of this, right? I had lots of vets who were on alprazolam, Xanax, 2 milligrams 5 times a day, and they would come in to me and I would see them on that dose and I would think, good heavens, how did you get up there? What they were wanting is a state of numbness throughout the day. And that made them feel better, but it actually kept them from getting better, right? Because they never faced up to what they were avoiding. This was just continuing their avoiding. And so sometimes the act of prescribing actually impedes true improvement and true progress. So I'm going to lay that idea down. And a lot of this that we're talking about, and a lot of the benefits, I'm going to shift now to the placebo and nocebo effects. Placebo is we're all familiar with that. It's a positive effect on health. It's not explained by pharmacology. It's not explained by the active ingredient in that pill. Nocebo effect, if you've not heard of that term, is a negative effect on health that's not explained by pharmacology. We see this all the time in clinical settings and in treatment settings. We see this all over the place. That's why we do randomized controlled trials with placebo, because there's such a strong placebo response that so many patients, especially when you're dealing with psychiatric issues or pain, so many patients have a placebo response that it's sometimes difficult to prove that the active medication is working. And the basis for the response, we'll talk about that here in a minute, but it comes from a wide variety of areas. It comes from their personal experiences. It comes from the experiences of friends and family. My sister responded to this medication. I think I would respond to that medication. Well, you know what? They're actually more likely to respond to that medication because of that family experience. News reports, advertisements, biases. And I think, maybe you all are not, maybe not all of you are old enough to have seen this. I am certainly old enough to have seen this, where you get the wonder drug phenomenon. Something will be approved, it'll be put on the market, and suddenly it is the treatment for everything. They're trying everything, and everything is responding to it, and everyone is getting better on this one magic pill until it stops, until they're not getting better anymore. There's this kind of euphoria that exists for a while around the pill, and I've seen it in several actually, where this intervention or this pill is going to be the cure, and a lot of patients respond. But then over time, you start seeing those response rates drop. You start seeing more and more side effects that weren't being reported before. And it's not the medication that's changed. It's a loss of that placebo effect, that halo effect that they get when that new medicine comes out. So again, the impact, we've already talked about how often in trials or psychiatric trials and pain management trials, placebo effect is just as high or nearly as high as the active treatment. But nocebo effect is there as well. 1 out of 5 adults taking an inactive pill, so taking a placebo pill, report side effects to them. It's pharmacologically inactive, but they still have side effects. That's a nocebo effect. Telling someone that you're about to get a strong, very, very potent painkiller. This is so strong, I'm not even sure I should give it to you. I'm not sure it's safe, but I'm going to try it. It's really, really powerful. That's going to lead to a greater reduction of pain than just saying, here's something that might help your pain, right? So the more you build it up, the more you create that idea in their head that they're going to have a positive effect, the more likely they are to have a positive effect. But equally, if you emphasize side effects too much, they're more likely to have the side effects that you've emphasized. A lot of people have insomnia on this medication. A lot of people get jittery on this medication. A lot of people have nausea on this medication. If you lay that idea, that expectation in their head, then suddenly they're having those problems. And you will sometimes we struggle with this idea is the placebo effect or the nocebo effect all in their head? Well, yeah, kind of, because that's where the brain lives, right? But it's in their head, but it's not in their imagination. There's actually demonstrable things that happen. The placebo effect, for example, is associated with the release of endogenous opioids and endocannabinoids, right? You feel better. You literally feel better because your system is being flooded with these medicines, with these drugs that make you feel better. It releases dopamine, oxytocin, vasopressin, right? All of these that make you feel close and bonded and happy and whole are released as part of the placebo effect. So it's not in their imagination. And the nocebo effect, when they're having worse side effects or things are getting worse, is not in their imagination either. This was studies that they looked at pain, where you could suggest this is going to be really, really painful. This is going to be really hurt. This is going to hurt a lot. What you saw in those patients was increased release of cholecystokinin and activation of the HPA axis. They feel they're being attacked. They feel they're under threat because of this medication, and their body is responding to that threat. And where does that come from? Well, some of it is just learning and classical conditioning, right? You're pairing neutral stimuli, like the shape of a pill or the color of a pill or just having a pill, with either some beneficial effect for placebo or adverse stimuli in nocebo. The famous example of this, and I've seen it in my own family, is someone who's undergoing chemotherapy. They get nauseous in the parking lot. As they're pulling into the oncologist's office, they get nauseous in that parking lot. There's no pharmacologic explanation for that, but they have paired being in that place with being nauseous. And so that's part of what nocebo is. And the other is these expectation and self-fulfilling prophecy. When you've heard from a lot of people, that this is going to help, this is going to benefit you, then you're just expecting it, and you look for evidence that it's helping. If you're being told this is going to hurt you, this is going to be a problem, then you're looking for evidence that it's a problem, and it becomes a very self-fulfilling prophecy. But again, it's modulated by the brain. It's not in their imagination. One of the areas most involved in this is ventromedial prefrontal cortex. So right here, right underneath your skull, right there. And it's involved in what's called the salience network. And the salience network appraises the significance and threat from internal and external stimuli. It's always looking at your surroundings. It's always looking at symptoms, at the sensory input, at context, and coming up with, is this bad? Is this good? Am I expecting something bad? Am I expecting something good? It combines prior experiences, predictions with incoming sensory data, and then impacts or influences the experience by descending pathways. So it's actually changing the brain's response based on these perceptions, based on these anticipation, based on the expectation. So again, real physical responses. So we have another opportunity for you to kind of kick in. You can type this if you want. It might be helpful for someone to go unmute because this might be longer. But Mr. Jones, a patient, has started an SSRI 2 weeks ago for his major depressive disorder. He comes in today reporting that after 1 week, he felt significant improvement in all of his symptoms. He felt well. He says, but doc, I remember that you told me it might take 4 to 6 weeks for these medications to kick in. Does that mean my improvement isn't real? Does that mean my depression was all in my head? Does that mean that I just imagined my symptoms? So how would folks respond to that? If anyone would like to unmute, or if you're a fast typist, go ahead and put it in the chat.
I'd like to unmute and say that I've had many patients who had that kind of response. And what I say to them is that everyone is different. There are some people indeed who report a response within a couple of days. And the fact that you had such a response, that is wonderful. That tells us that you are one of those people that respond well to this medication, and that improves your chances of recovery and getting well.
Yep, good. And Amelia put it very similar. No, it's not in your imagination at all. You are just an early responder. Yeah. So what you all are saying is this is, don't worry about the exact wording of this, but this is kind of my idea. I'm going to do three things with this patient. The first is I'm going to acknowledge the real improvement. This is real. There is no, the second thing is I'm going to acknowledge limitations of science. And the third is to provide a general explanation, enough of an explanation that they can hang their hat on and feel good about it. So, Mr. Jones, there's no doubt that a couple of weeks ago, you were feeling miserable. You were suffering. I know that, and you know that. There's also no doubt that you're feeling much better and have been for the last several days. That is fantastic. I'm delighted that you're feeling so much better, right? So I've acknowledged, no, it's real. They've responded, and it's a real response. Then the limitations of science. While these medications do take several weeks to kick in, I have had lots of patients who, like you, have had a response much more quickly than that, who've responded within days of starting, or certainly within a week or two. I can't explain that. Our science can't explain why some people respond that quickly, while most of the time it takes much, much longer. I can't explain the science, but they feel better just like you're feeling better. And then my general kind of thumbnail explanation is my best attempt to explain it is that the brain and the body are a whole lot smarter than doctors. And sometimes the body doesn't wait for doctors and their medications to start the healing process. The medications will help you feel better. We know that from the science. But just opening up to someone and sharing your problems, just working with someone to feel better, just that starts the healing process. Having some hope for your future, which maybe you didn't have before, that starts the healing process. And all of those things are working together. And the medication is part of it. The hope is part of it. The fact that we're a team working together, that's part of it. All of those things are coming together to help you feel better. And exactly what is contributing what, that I can't say. But what we can say is that you're doing much better, and I'm really happy about it. Okay. So that kind of idea. So just a couple of pearls to maximize the placebo effect and to minimize the nocebo effect. There is a big problem if you're talked about already, and someone had already talked about the engagement and the alliance and how important it is to have that good relationship. If you have a patient who doesn't feel connected, if you want to use kind of psychodynamic terms, it's an insecure attachment, but it's basically that idea of someone who doesn't feel that they can trust you, doesn't feel that you're going to be there when they really need you, doesn't feel that you're in it for the long haul. If they're anxious about their relationship with you, they're much less likely to respond to the medicine. And so what you need to do, besides trumpeting the value of the medicine, is to take time to shore up that relationship. Make sure that you're using empathy and validation to create a positive bond between the two of you. Make sure that you express respect for them, concern for them, that you are really invested in them as a person. You really want them to feel better. Make sure that you've identified and you're working together as a team toward goals that you've picked, and let them know your availability. I can't tell you the number of times I've had patients who said, well, what if this medicine doesn't work? Well, if this doesn't work, we will try something else, and we will try something else, and we will keep trying it until we find something that helps you feel better, because that is my commitment to you, right? And it shows that we're working together. And again, that is going to shore up that relationship, and having that good relationship, having that good alliance is a key to them responding to the medication. You can also explore their expectations. What do you expect from this medicine? Because if their expectations are unrealistic, well, I expect that I will never feel sad again. No, that's not what this medicine is going to do. So if they have unrealistic expectations, it makes non-adherence more likely. So you need to make sure that they have an understanding of what is realistic, kind of a fact-based but hopeful description of what the medication does. This is not something that's going to make you feel better tomorrow. This is something that's going to take several weeks to kick in, but will help you feel better, because it helps most people feel better. Another thing is about side effects. You certainly need to warn them about serious and common side effects, but then ask them, how much do they want to know about the side effects that are more rare or more annoying? There are people who want to know it all, right? They're going to go home and Google it anyway, so you might as well tell them everything you can think of. But there are some people who say, no, I don't want to know, because if I If you tell me what the side effects are, I'm going to start looking for that side effect and I'm more likely to have it. They realize that themselves. So ask how much they want to know. And then finally, if you ever do get into a discussion of the placebo effect, like we talked about, make sure you're emphasizing that it's neurobiologically based. Again, it's in your head because that's where your brain lives, but it's not in your imagination. It's real, and the impact is real. Okay. So that is kind of placebos. Now we're going to go talk about the meaning of medication, because often we really focus on the chemical of medication, the pharmacology of medication, but the meaning of medication can be really important. So starting a patient on an antidepressant, does that mean that they're broken, that they're defective, that they're helpless, that they're now dependent on you and they're dependent on the medication, which might be very uncomfortable for them? For those people, it's hard for them to stay on the medication because the medication is a constant reminder that they are broken, defective, ineffective, helpless. And so you need to address them when you talk with them. For other people, being on a medication is great because it validates their concerns and their complaints. You heard me. You believe me. You understand me, how much pain I'm in. You're responding. That's a great thing. They're likely to stay on that medication. Then there's other people where the medication is going to fix all of their problems. And that's not a helpful idea either. And so, you need to understand what the meaning of the medication is so that you can work with them. One of the topics that comes up here is the idea of locus of control. What is it that influences their experience in life? And an internal locus of control is that person who thinks, I'm in charge of my own destiny to a large degree. I control how I respond. I control how I think. To some degree, I control how I feel. I have an active influence in how I get through life. An external locus of control is that person who is always something else. I am the victim of my circumstances. I am the victim of my surroundings. I'm the victim of my history. I am helpless in the face of other people who are doing things to me. And the people who have an internal locus of control are much more likely to respond to our medications. And so we want to promote that. We want to promote that they can help themselves feel better. And one of the ways that they can help themselves feel better is by committing to this medication, by taking it every day, not just when they feel like taking it, not just when they wake up feeling sad, but you need to take this every day because that's one of the things you're doing to help yourself feel better. And what you find is that those people have more of an internal locus of control, a sense of autonomy. I'm doing this for myself. I'm not doing it to please other people. I'm doing it for myself. Those people are going to have a better response to the medications. And so we want to instill that idea that this is something you are doing for yourself. So we want to discuss the meaning of being on a medication, discuss that the goal of this appointment is not for you to be on more pills. The goal of this appointment is for you to feel better, for you to function better. And if we can do that without changing medicines or without starting a medicine, that's great. That's fantastic. That's what we want to do. Don't feel it's a wasted appointment if you're not on the pill. And then again, if they see medication as a sign of failure or weakness, we'll want to emphasize that taking medication is a way of taking active control of their life and their problem. And then the last one is reasons to prescribe. We'll have a little bit of a discussion, then we're going to do breakout groups here in a second. But I came up, this is just mine, so nothing special about this. Why do we prescribe medications? I came up with 3 basic reasons. 1, because there is good scientific evidence to prescribe. 2, because there's not good scientific evidence to prescribe, but there's something about the patient that leads us to prescribe. Or 3, there's not good scientific evidence to prescribe, but there's something about us as providers that is leading us to prescribe. These are not mutually exclusive. These overlap and all that kind of stuff. But there's 3 different categories. And the first is the easiest one, right? There's scientific evidence. There's, anecdotal experience or personal experience. I've seen this medication work. I know it works. Or you have expert panels and, you have that, hierarchy of levels of evidence up to meta-analysis. Right. And that tells us for this patient with this condition, this medication or this class of medication is the right thing to do. That's, what evidence-based medicine is all about. That's how we should be prescribing. But that's not always what we do. There are some times when the patient wants us to prescribe or change medications, and there really isn't good science behind it. Why might they want this? We can either put that in the chat or unmute. What are some of the patient factors that lead us to change medications or start medications, add medications, when there really isn't science behind it. Any thoughts? They paid a copay and they want something. The sense of, yeah, I paid for this. And you owe me. You owe me something. Good. Yeah. Other pressure from family members, right? You need to be on a pill. We're not going to take this anymore. You need to, you need to change. You need to do something. External struggles, CPS, legal problems, right? There's all those external forces. And if there's external forces making your life miserable, then an external force like the pill should make your life better. Right. And sometimes they're just simply still suffering. They're still miserable. They're not better. They just want to be better. And the best thing they can think of is give me a pill and make me better. I understand that. We're not criticizing them. We got that. If we're miserable, we want someone to make it all better as well. But sometimes they have to recognize that no pill will ever do that. Again, sometimes it's a way of validating their experience, validating their illness, validating their complaints. You're the one person who believes in me. Often it's wanting a quick fix, or it's pressure, or being influenced, someone saying, you need to be on this pill because it really helped me. So they come in with all of those expectations. And again, if we're not taking time to talk to them about what's their expectation of the medicine, what's the motivation behind the medicine, you'll never discover that. So, so it leads to this question of how much do patients' wishes impact our prescribing? Assuming it's not dangerous, how often do providers acquiesce to the patient's request for dose or medication changes? Let me stop there. And I'm not asking you to talk about yourself. I'm asking you to talk about other providers that you know. What about this question? How often, assuming the patient's not asking for high doses of benzos or opiates or something, they're just wanting a change in their antidepressant, they're wanting a change in their mood stabilizer, change in their antipsychotic, whatever it is. And there's not really a good scientific reason to do it. How often do providers acquiesce and just say, yeah, let's go ahead with it? Is there a sense of that? Is that something you think happens commonly? Is it rare? Are people holding the scientific line? Yeah, certainly it's going to depend on the situation. Under your thinking it's common. My guess is what, oh, Russell, were you gonna, yeah.
Oh, I don't know for psychotropics. I think less maybe, but I always heard about it a lot for like amoxicillin and stuff, where people would go, they pay $25, they'd have something, and they, some kind of thing that was probably not bacterial, and would be requesting that,
Yeah.
and then they would get prescribed anyways.
Oh yeah, yeah.
Yeah.
The number of viral, kind of URIs that have ended up with a Z-Pack, just because someone, I need something, I need something. And I think it happens a lot with us, especially in the world of antidepressants, where people get a second or, a switch between. Okay. And these are some of the provider factors as well, because there's things about us, right? We don't like feeling powerless. And when we have a patient who's not doing well, who is still suffering, just saying, there isn't really any good science, I guess we shouldn't make any changes, that feels uncomfortable. We don't like that. We want to do something different. We want to have made an active involvement. This idea, and this was a quote actually from a nurse working in a clinic, an appointment without a new or changed medication is a wasted appointment, right? You've wasted their time, wasted your time, wasted their money. You need to change something. And then sometimes it's just easier to give in than it is to fight with the patient who wants something, who wants that Z-Pack for their cold. Yes, you can fight it, you can explain about it. Yes, but it's easier just to say, okay, yeah, fine, it's not going to hurt much. And Amelia, yes, a third of patients that, yeah, it's good. That's a good estimate. Yeah, are refractory to treatment, and that's hard for us to accept. When we have done everything we can reasonably do, that makes us feel powerless. We don't like that. And so sometimes that leads us to make changes, and it's really not a good reason. So, okay, so here's a question. This is a 45-year-old, significantly overweight patient who has type 2 diabetes with poorly controlled blood sugars and a hemoglobin A1C consistently over 9%. She has tried 3 different medications to control her blood sugar, including combinations of them without success. She does not exercise because I don't have the time. Although the value of decreasing her weight has been discussed repeatedly, she has never been successful in dieting. I get too hungry, and besides, I don't think I eat too much. The physician believes lifestyle modification is crucial to controlling her blood sugar. She wants to try the newest diabetes medication. How does this story end? Oh. Oh. I think for a lot of times, she gets this new medication. Even if we're thinking, there's maybe not a good reason for it, maybe there's not the best scientific fact for it, she is still going to get the medication because it is just easier. It ends with Ozempic. Yeah, exactly. I had a patient talking with me about that today. Yeah, it's because I'm afraid I'm going to gain some weight. So I want to be on a pill to make sure I don't. So, okay. So what we're going to do, that is the end of my prepared slides. And again, have I exhausted the topic? No, I have not. We've talked about a lot of different things involving placebos. And what we're going to do is we're going to try to put people into breakout groups so you have a chance to talk with a few others. And the questions are 3, and we'll put this, I'll put this into the chat. But how do you address or manage the placebo response in your patients? Is this something you look for? Is this something you ask about? How do you respond when it happens? How do you, thank you, Sarah. How do you respond to patients who request or demand specific medications? And then 3rd, how comfortable are you in not changing medications with a still symptomatic patient when there's no real good scientific evidence to do so? The best one, the most common example probably is that person who's been on an antidepressant for a week and they don't feel better yet. And so this medicine isn't working. I need something else. How comfortable are you in saying, no, there's no reason to change it? So we're going to, let me stop sharing. So what I'd like to do, if we can,